Hello, everyone, and welcome to our next episode of the ASSFN Neurosurgery podcast. Today, I'm pleased to have our guest speaker, Dr. Kelly Foote, with us, and we're going to be discussing deep brain stimulation for Parkinson's disease and differentiating the two most common targets of the subthalamic nucleus and globus pallidus internus. So to introduce our speaker, Dr. Foote is a current professor of neurosurgery at the University of Florida College of Medicine and the co-director of the Normal Fixel Institute for Neurological Diseases at UF Health. He's actually one of the few neurosurgeons with fellowship training in both movement disorders neurology and deep brain stimulation. He's performed nearly 2,000 DBS surgeries since joining UF in 2002, and he's published more than 185 peer-reviewed research articles in the fields of deep brain stimulation, and several focusing on this topic that we're going to discuss today, GPI versus STN DBS for Parkinson's disease. Now, he was a co-author on an editorial that appeared in the Archives of Neurology back in 2005 on this topic. And it highlighted some important differences between these two targets. As many of you may know, deep brain stimulation is a particularly useful intervention for treatment of Parkinson's disease. It's estimated that about 10 to 20% of patients with advanced Parkinson's disease may be appropriate surgical candidates. This intervention is often employed later in the disease, but intervention earlier has expanded the number of people who may benefit. And it's important to tailor the treatment specifics to get the best patient outcome. So it's important to discuss this topic and thoughtful preoperative planning of surgical target and lots of other considerations. So Dr. Foote, thank you so much for being here to speak with us on this topic today.
It's my pleasure. Thanks, Danika.
So can you briefly describe the anatomical and circuitry differences between these two structures, the subthalamic nucleus and globus pallidus internus? And are there temporal response differences to DBS between these two targeted regions?
Sure. Well, discussing extensive anatomy and circuitry is probably not the most interesting way to approach this, but what I will say is conceptually, I think a very useful way to think about STN and GPI are that they are nodes in the motor circuit, and they carry similar information. And in the STN, that circuitry is much more densely compacted. In the GPI, you have similar circuitry that is carried in a greater volume, almost 3 times the volume for the same circuitry. And the reason that matters is predictably, you get more bang for your buck in terms of energy input versus circuitry affected in STN because it's more densely compacted than you do in GPI, which is an advantage. But the predictable disadvantage is because the circuitry is so compacted in and around the STN, it is more difficult to isolate circuits and not to affect surrounding circuits. I think it's important to think about deep brain stimulation as, disrupting abnormal signal as much as you can to the benefit of the patient, but knowing that there's always going to be some disruption of normal information flow, so there will be a trade-off. So what the advantage in concept that the larger GPI target gives you is the ability to stimulate more precisely what you're trying to stimulate without affecting surrounding circuitry. And then with regard to the question about temporal responses, I think the most salient difference in temporal responses is what we observe in tremor. for a long time, I was absolutely convinced that STN was more effective at suppressing tremor than GPI. And I think most people who have done a lot of deep brain stimulation on awake patients are convinced of that because intraoperatively, STN is absolutely more effective at suppressing tremor than GPI. And we designed several studies over the years to prove that STN was more effective than GPI at suppressing tremor. And remarkably, most of those studies failed to show a difference in tremor suppression between STN and GPI. And ultimately, after studying it like 4 or 5 times, we've learned that there are some nuances about tremor in these targets, and one of them is the temporal response. The temporal response to tremor in STN is much quicker, but we very typically get similar suppression of tremor, of resting tremor in GPI to that we see in STN. It just shows up, sometimes weeks to months later. And by the way, while we're on tremor between the two targets, for those uncommon patients with Parkinson's disease who have a predominant component of intention tremor, action tremor, that's more characteristic of essential tremor, those patients, I think, do better in STN.
Great. Yeah, and in that same vein, studies in general have demonstrated non-superiority when looking at the total UPDRS, or Unified Parkinson's Disease Rating Scale, the scale that summarizes the motor symptoms and overall mentation and behavior in Parkinson's disease. But there's been notable differences in those subcomponents, as you mentioned, with tremor. Are you seeing differences in GPI versus STN with bradykinesia or dyskinesia or gait imbalances?
Yeah, I think we see some important differences. Interestingly, when we did our first randomized prospective trial of STN versus GPI, our objective was to figure out which of the two targets was the best, which one should we be using for our Parkinson patients. And what we gradually learned after 20 years of studying this is that both targets are quite effective, but there are nuances, and certainly for certain problems, one target may be better than the other. And that goes to the notion that you mentioned earlier about tailoring the treatment to the needs of a given patient. So we invest a lot of time in getting to know the patient and what the patient's most significant problems are, and tailoring the entire intervention to maximize benefit and minimize risk that's specific to them. So examples are, as you said, dyskinesia. I think that stimulation of the GPI is very reliable for suppressing dyskinesia actively. In STN, we get some direct dyskinesia suppression, but not reliably. And much more commonly in STN than GPI, we get stimulation-induced dyskinesia, which can be problematic, of course. So in patients, with every single patient, I go through this exercise where I say, what bothers you the most, or what symptom, if we could diminish this symptom, which one would make the biggest difference in your quality of life? Mm-hmm. And for patients who list either as their top or second symptom that is problematic for them, dyskinesia, I am strongly leaning toward GPI for those folks because, I think that's a much more reliable target for dyskinesia suppression.
Right. Right.
With regard to the other thing you asked about was gait and balance, Kim Burchell and his group did a couple of, I think, interesting small trials looking at STN versus GPI for gait and balance, and their finding was that DBS surgery in either target has an adverse effect on gait and balance, but it also has a beneficial effect. And the net effect in STN was a slight worsening of gait and balance overall. And the net effect of GPI on gait and balance was a slight improvement overall. So we have it's not a strong leaning, but for patients who really have significant gait and balance problems, I guess I would say I lean a little bit toward GPI, but I wouldn't rule out STN based on that alone.
Right, understandable. Yeah, it's important to consider definitely what is the most important to the patient as they're center to this whole process. What about for patients that present with other non-motor components of their disease, such as cognitive and mood symptoms, or which target do you consider or prefer for medication reduction or long-term flexibility with medications? And lastly, what about cost effectiveness?
Actually, that's an interesting question. The COMPARE trial, which was a prospective trial of STN versus GPI, the primary outcomes that we were measuring in that trial were cognition and mood. So we were directly measuring those things. And interestingly, the thing people cite about that paper was the non-superiority of STN or GPI over the other in terms of motor symptoms. But what I thought was one of the most important findings in that trial, which was prospective and randomized, was that the incidence of limbic, I will call them limbic adverse events, was substantially higher in the STN patient cohort than in the GPI patient cohort, which I guess makes some intuitive sense based on that notion of affecting surrounding circuitry inadvertently. And I think in STN, it's harder not to affect limbic circuitry to isolate the motor circuitry than it is in GPI. So for patients who have significant psychiatric issues, I actually tend toward GPI. And for the reasons that I outlined at the beginning, for most risk, I think GPI in general is the lower risk target for most things, but STN is the greater benefit target or more bang for your buck target for most things because the anatomical differences that we talked about. So, one of your questions was cost effectiveness and economic profiles, and certainly the battery is predictably going to last longer in STN because you can have a more robust effect with less energy input in that smaller volume. I have to admit that cost effectiveness in my decision making between STN and GPI takes a distant back seat compared to maximizing benefit for a given patient or minimizing risk. And then the other thing you mentioned about long-term flexibility with medications, I think is something that the shorter trials kind of ignore because STN DBS is very effective for many and most people with Parkinson's disease. There's a reason it's the most commonly used target. We can talk more about that, I guess, in a minute. But I think that it's not terribly uncommon after several years of STN DBS to, as the patient's Parkinson's disease symptoms progress, and you've sort of maximized the benefit that you can achieve with DBS, and you would like to add more dopaminergic medication, A lot of times STN DBS has a limitation because you just don't get that dyskinesia suppression. So in some ways, GPI is a more forgiving target over the long term.
Right. Understandable. So you mentioned that STN is the most commonly used target by neurosurgeons, and why do you think that is? Do you think it is because you're able to modulate more circuits, with the more densely packed target, because of the cost effectiveness? Why do you think that this target has become kind of paramount?
Well, the honest, somewhat controversial answer that I would give to that question is because we as neurosurgeons, and I think especially functional neurosurgeons, tend to be mentor worshipers. Um, our mentors teach us how to do an operation, and we learn these, sacred steps, and this wonderful, magical effect occurs when we do it the way we're taught, and it's pretty hard to deviate from, the magic. I think Professor Benabid is in some ways a mentor to all of us. And he became absolutely convinced that STN was a better target than GPI for the treatment of Parkinson's disease. Now, I have an alternate view on that, and Professor Benabid is one of my direct mentors, and I have more respect and admiration for him than you can imagine. But what I think is the methodology he was using to target, which was largely indirect targeting based on an atlas, when he was exploring GPI versus STN at the very beginning of all of this. His first 15 DBS cases for Parkinson's were GPI cases. He was trying to recapitulate the pallidotomy experience with deep brain stimulation in the same way he had done with thalamotomy for tremor. And he had pretty inconsistent results with pallidal DBS at the beginning. He had essentially 5, 5, and 5. 5 patients who did great, 5 patients who did okay, and 5 patients who didn't have good outcomes. And he was not satisfied with that ratio. So this was about the same time that Malin DeLong and his group were publishing subthalamotomy in monkeys. And so Benabid switched based on DeLong's work to STN DBS to give that a try, and had much more consistent results. Now, I actually looked back at his targeting at those 15 cases, and my contention is that the STN is from patient to patient in a much more consistent position relative to the mid-commissural point than the GPI, especially in the medial lateral. So if you're going to Cartesian coordinates to implant the STN, you're much more likely to be consistently right than if you go to a set of Cartesian coordinates to implant the GPI, because in one patient, the ideal GPI target will be at 19 millimeters lateral to midline, and in another patient, it will be at 24. So I think that STN is a better target if you're using indirect targeting. And I think that if you're using modern targeting, direct targeting based on high quality imaging and perhaps an atlas that's matched to a given patient, then either target you can target quite effectively. You just have to ignore the Cartesian coordinates and target directly.
Great. And then transitioning that into clinical practice, how do you decide which target you're going to aim for? Like, what does the, I guess, prototypical GPI patient look like? And what does the prototypical STN patient look like? Obviously, there's not a one size fits all for these. As we mentioned previously, you have to tailor all of this to the patient's needs and desires, what they want out of their therapy. But if you could kind of say the highlights of, a patient that would benefit from GPI targeting versus a patient that would benefit from STN targeting, what kind of characteristics would you?
Sure. I think I've sort of touched on this a little bit already, but I would say the typical STN patient for me is a patient who has a low overall risk, so perhaps a younger, healthier patient, a patient that has tremor as their primary problem. I would lean more heavily toward STN. Patients who are taking a lot of medication and really don't want to and meet those other two criteria, I think make good STN patients. The GPI patient is sort of the inverse of that. The patient that has significantly high risk, an older patient who maybe has multiple health problems or psychiatric problems or cognitive issues. One of the most interesting findings over time, we started doing neuropsychological testing on every patient before and after DBS surgery to try to assess what kind of effects we were having on cognitive function with our surgical intervention. And one of the interesting observations that was unexpected was that STN fairly consistently produced a modest worsening of verbal fluency on cognitive testing. Somebody would, prior to DBS, come up with 12 words that start with the letter S in a minute, and then afterwards, after DBS, when we retest them 4 months later, they would come up with 10 words, and that in isolation would be unremarkable. And frankly, but actually, it was consistent and it was happening routinely. And the patients, frankly, didn't care because the vast majority of them were super happy that their motor symptoms had improved so much. And the difference between 12 and 10 words on a Thurstone test don't make a significant difference in quality of life. So it was, I think, not much of a factor. But what it does for us now is occasionally you'll have a patient come in who has verbal fluency problems at baseline. That's picked up by the neuropsychologists in their preoperative testing. And then when we have our discussion as a group to come to a consensus about what to recommend for a given patient, that patient, the neuropsychologist is going to say, well, this patient has verbal fluency problems, and I think you should choose GPI because STN DBS tends to cause a mild worsening of verbal fluency, whereas GPI didn't do that. So that's one example, but there are a whole bunch of different examples in a bunch of different domains that, as you say, kind of you have to take the sum of all of these factors. But I guess the main theme is high-risk patients tend to be more GPI and low-risk patients tend to be more STN.
Sure. Yeah, thank you. That's a great summary. And what about the decision to implant unilateral versus bilateral leads? At our institution, most patients undergo bilateral lead placement, but for one target versus the other, are you more likely to do bilateral placement, or can unilateral work as well in a particular subset of patients?
Actually, to be honest with you, I have over the years become increasingly intolerant of adverse effects, even transient adverse effects. And in my hands, and using the methodology that we tend to use, which is a week DBS surgery with multiple lines of intraoperative physiology to inform our ultimate lead position. I have better results if I operate on one side of the brain at a time. The incidence of the patient staying an extra day or two in the hospital because they're confused or disoriented, or the incidence of having transient dysarthria or walking trouble is in my practice higher if I operate on both sides of the brain on the same day. If I operate on one side of the brain and just do a single lead implantation, then I make that operation 2.5 hour procedure for the patient, which is a bit more tolerable. And the vast majority of the patients go home the next morning feeling fine and resume their normal lives within a day or two. Whereas if I operate on both sides of the brain on the same day, there's just a slightly higher percentage of patients who end up spending a week in the hospital, or being stressed out because they're not talking right. But there's obviously, I think, one of the interesting aspects of this question that you just asked is, or parts of the answer is, it really depends on your methodology. I am much more likely, in those rare patients where I do a sleep DBS, I'm much more likely to do a bilateral procedure, because I can do it more efficiently and it's better tolerated by the patient. However, I remain convinced that intraoperative physiology, the way our team uses it, results in better outcomes for our patients. So even though it's a significant investment of time, resources, and energy on my part, I think I get better results awake. And when I'm operating on awake patients, I think I get better results when I do smaller unilateral operations and stage the procedures.
Right, understandable. That's a great insight, and thank you for sharing your experience with us. Recently, there was a study published out of a Duke group in neurosurgery this past month that looked at bilateral implantation of both STN and GPI leads that showed promising results. So, what are your thoughts on the idea of utilizing both targets in PD patients?
Well, I think that there is cumulative benefit from stimulating both targets, and I certainly have, over the years, implanted STN and GPI in a fair number of patients. I think doing that up front, in my hands, would result in more perioperative adverse effects that I'm not willing to accept. So I wouldn't choose to implant 4 DBS leads in a very short period of time, because I think, especially in older patients, the brain doesn't like to be messed with. And I think that is going to result, if we carefully follow adverse effects, in more adverse events and more problems. So when I do implant STN and GPI in the same patient, or when I do what we call rescue procedures, where we're afraid to take out the existing DBS system because it's giving modest benefit, and we wouldn't want to lose the benefit that they're getting, but we believe we could get a lot more, then we'll add a rescue lead in another target that we think is going to be additive in benefit as well. But I wouldn't do that up front, because I think I'd have more adverse effects. The one exception to that is, and this isn't STN versus GPI, but I will, in patients who have very severe tremor, sometimes implant a VIM DBS lead and a VO thalamic DBS lead in the same procedure if I don't get intraoperatively the kind of tremor suppression that I'm hoping for with the VIM.
Mm-hmm. Right. Great.
So I guess the answer is I'm not a big fan of just indiscriminately implanting 4 leads in every patient.
Mm-hmm.
I think the risk-benefit ratio in my hands isn't right for that.
Right. Okay. And it would definitely take a certain patient population that would benefit from, rescue leads or having multiple leads. And kind of in line with that, where do you think we stand on the progress we've made towards personalizing DBS therapy and tailoring the approach to each patient? And where do you think we can improve the most in this regard going forward?
I love that question. I just actually really like that you asked that question. And I appreciated that at the beginning of this, in your introduction, you said it so matter-of-factly that we should be tailoring these interventions to the needs of a given patient, because that, frankly, is not a universally held belief. I've been sort of, Michael Oken and I have been sort of crusading on that point for a long, long time. And I do think that, if we're careful and we do a careful interdisciplinary risk-benefit analysis and get a bunch of input, we can tailor the intervention to the needs of each patient to maximize this patient's benefit and minimize this particular patient's risk based on their profiles. But I still believe that probably at least 50% of the DBS implanting centers do one operation for every single patient with Parkinson's disease. They have the same operation and they do the same operation for everyone. So I thank you for asking that question the way you did, as if it were a widely held truth that we should be tailoring. But I personally believe we should, and I do think that attitudes are changing in that regard, and I think more people are saying, "Hey, that does make sense." I think we're making a lot of progress. I think ultimately the ultimate tailoring, or one of the biggest improvements in patient tailoring, is going to be when we figure out how to effectively use closed loop DBS or adaptive DBS, so that we're not only tailoring target selection, but we're tailoring the degree of stimulation or no stimulation that we deliver in a time-dependent way based on the patient's current state. So that's going to be really ultimately tailored. And I think that's probably, what the next phase of smart DBS and us getting better.
Great. Yeah, I'm definitely looking forward to, seeing how this progresses over the next years and decades. And I hope we really can tailor this therapy and get the best outcomes for our patients that are possible. And with new technologies such as adaptive DBS and even better imaging, I think that will support our ability to do so. Well, thanks for having this great discussion with me. Is there anything else, any final points or thoughts that you want to leave our listeners with?
I don't think so. I just want to thank you, Danika. This was a pleasure.
All right. Yes, it was a pleasure on my end as well. Thank you, Dr. Foote, for taking the time to talk with us. And stay tuned for our next episode. Again, if you want to follow us on Twitter, it's at ASSF Neurosurge. And stay tuned for our next episode. Thanks for taking a listen.